Hello, everybody. I would like to thank the organizing committee and GE for this kind invitation to speak at the Camargo Cancer Center. My name is Ángel de Francisco, and I am speaking from this place in Santander in the north of Spain. And I am working at the University Hospital Valdecilla, which is included in the slide. These are my disclosure. And what I want to discuss today with you is based in the different risk factors for post-construct acute kidney injury. You see, this is the European Society of Urogenital Radiology guidelines related to the risk factor for acute kidney injury. And as you can see here in the previous guidelines, they include all the risk factors that we, the nephrologists, we agree with that, such as diabetes, advanced chronic heart failure, and many other sepsis, nephrotoxic drugs, use of contrast media. However, the very recent guidelines, they have excluded many of these risk factors for post-contrast acute kidney injury. And we do not agree with such exclusion because this was based on criteria on observational retrospective study with very important selective bias and very low degree of evidence. So that use of contrast media has been excluded, and many others such as diabetes and advanced chronic heart failure. But which is important and I would like to discuss with you today is why cancer is not considered a risk factor for acute kidney injury post-contrast administration. And the reason why malignancy should be considered as a risk factor for PCAKI is, first of all, because acute kidney injury incidence is higher in cancer patients. It's in the acute kidney injury in cancer patient at 1 year risk was 17% and 5 year risk 27%. And when we look at the patient hospitalized without cancer, the acute kidney injury incidence was 5% and compared with 12% in oncological patients. And also we will look at the critically ill patient in which those with cancer, they will need more renal replacement therapy, such as dialysis, 42% versus patient without cancer, such as 13%. If we look at this slide, this is more than almost 30 million inpatient visits in Premier Hospital database in more than 600 hospitals. As you can see here, the absolute risk of composite of acute kidney adverse event, it's ×3 when they receive contrast medium. But if at the same time that they receive contrast medium, they have cancer, the total absolute risk is ×5, which is increasing also with the different degrees of chronic kidney disease. Cancer is just one of the main factors for the acute kidney injury related to contrast medium administration. The second reason why malignancy should be considered a risk factor for post-contrast acute kidney injury is that the oncological patient has higher degree of pre-existing kidney dysfunction. For example, in the BIRMA study, you can see here that 18% of patients of different cancer, they have a chronic kidney disease with a GFR lower than 60 milliliters per minute. In other studies, it's is even greater, such as 22%, 25%. And in our study in 10 big center in Spain with more than 14,000 patients, adult patients, the percentage of cancer patient in oncology with GFR lower than 60 milliliter per minute was 18%. Another reason why malignancy should be considered a risk factor for post-contrast acute kidney injury is that the oncological patient, they are living in a nephrotoxic atmosphere. 50% of anti-cancer drugs are excreted in the urine, and 80% of the patients, they are receiving nephrotoxic drugs, such as non-steroidal anti-inflammatory drugs or chemotherapy or immunotherapy or whatever. And this is extremely important because many times or sometimes, the risk of acute kidney injury in high-risk patients, it is related to the distance in days that in days when they receive for example, cisplatin. So the difference in days is extremely important in order to avoid in the same day or even in the same week to administer cisplatin or and contrast medium. And other reason why malignancy should be considered a high risk factor for this post-contrast acute kidney injury is that the guidelines, they recommend very frequently different procedures in oncology patients, which are based in the administration of iodinated contrast. Sometimes every 3 months, every 6 months during the first 2 or 3 years, and even annually up to 5 or even 10 years later, so that these patients, they are receiving contrast medium very frequently. The repetition of radiological study with administration of contrast medium is the case, as is the case in some cancer patients, increase the risk of acute kidney injury associated with contrast. And when we look at the Anderson data from the Anderson Cancer Center in more than 3,000 patients, we can see here that the contrast, intravenous contrast media, is one of the main reasons for the development of acute kidney injury. And one important subject to discuss here, why related to this repetition of radiological study with contrast medium, is that they develop sometimes subclinical acute kidney injury. What is subclinical acute kidney injury? So the patient, they stay with a normal GFR, but they develop tubular damage, and we are not aware of such a situation because they reduce the renal functional reserve. We will discuss that, in a moment. You see that you are perfectly aware that there is a cardiac reserve in the heart. So if this is the work that the heart is able to perform beyond that required under ordinary circumstances of daily life. So the heart is able to increase the cardiac output from 6 liters per minute up to 25 liters per minute. Well, the kidney as well, the kidney has a renal functional reserve. This renal functional reserve represents the ability of the kidney to increase the glomerular filtration rate in response to certain stimuli. For example, eating 1 kilogram of meat, or amino acid perfusion, or in pathological conditions, such as, for example, in the first step of the diabetes. So if this one example, how the GFR, due to the renal functional reserve, is able to increase up from 120 to 160 milliliters per minute. And it also shows how many chronic kidney disease patients or elderly, so they have a reduced in renal functional reserve. So if, as you can see in this slide, up to 50% of the nephrons can be damaged without any clinical impact on GFR or serum creatinine by recruitment of nephrons and use of renal functional reserve. So we can have patients receiving contrast medium many times. We do not see the damage because the normal renal the normal GFR is stable, although they are losing progressively the renal functional reserve. And this is which is really sometimes very important, because different kidney attacks, at the end, they develop chronic kidney disease. We can assess the renal functional reserve by a stress test in order to investigate if our patient, they have this renal functional reserve in the normal range or not. The only way to understand such a subclinical damage is not looking at the GFR, which is still is normal during a period of time. But the best way is try to study the clinical biomarker due to the tubular lesion, markers either inflammatory cell injury or other different markers of the cell cycle markers. So this is the way how we can investigate the damage introduced or produced by different toxic, and I include the contact media. But what is important, and why malignancy should be considered a risk factor is because of the osmolarity of the product of the contact media is a really important risk factor in cancer patients. And I will explain why it's so important. It is important because contact media, hyperosmolar contact media, induce hypoxia, tisular hypoxia, and the kidney is a very sensitive to hypoxia because the kidney is living in hypoxia. If we look at this ivory gull, which is living in the Arctic, always stand by the ice, you see that the blood temperature is 36 degrees centigrade. And the reason why they kept the temperature stable is because they have a circulatory adaptation, which is considered as countercurrent heat exchanges. So the artery is right to the vein, and the warm blood that descends past much of his heat to the cold blood that rises by conduction. So this possibility, which is the countercurrent, so the warm blood is moving up again, but the price is the space, is the price is the ischemia of the feet. And this happened exactly the same in the kidney. You know that we filter 180 liters per day, and we only pass urine about 2 liters per day. So there's a 99% reabsorption. And the way how the reabsorption is conducted without energy consumption is due to the countercurrent mechanism. The oxygen, in order to integrate osmolar gradient, in order to concentrate the urine, And this countercurrent mechanism in the oxygen diffuse directly from the arterial to the venous branch of the vasa recta, thus reducing the oxygen supply to the deeper portion of the medulla. And that's the reason why the kidney is living in hypoxia. If we look at the different contrast media, you are aware that there are ones that were hyperosmolar, and there has been excluded because of the kidney damage from the market. The following ones, they were named low osmolar. In fact, they are hyperosmolar as well. And finally, we have the iodixanol, which is the only one which has the same osmolarity as the blood, right? So it's the only one that is similar. The osmolarity is similar to the blood. So if we administer conscious media, there are three different potential interacting pathways in order to induce renal damage. The most important is it's a renal vasoconstriction, so the blood flow is 45 below basal levels at 4 hours, after 4 hours of administration of this conscious medium. So there's a reduction in the partial pressure of oxygen, and the clinical consequences are oxidative stress and finally ischemia. Also, there is also another mechanism, which is the direct cytotoxic effect of contrast medium and in the children. So these different interacting pathways are summarized, and the conclusion is that the higher the osmolarity of the contrast medium, the higher the oxygen requirement of the tubular cell, making them even more vulnerable to hypoxic injury and contrast-associated acute kidney injury. If we look at the guidelines that from the European Society of Urogenital Radiology, they assume that there are many meta-analyses that have shown no evidence that isoosmolar are associated with a significantly lower rate of post-contrast acute kidney injury than non-ionic low-osmolar contrast medium agent. And these are based in this 97 to 100 references. If we look at the number 27, McDonald in radiology, there are not any criteria to address these results. Neither in the reference 98, because isoosmolar is better than intra-arterial Exol with renal insufficiency. Reference 99 is better isoosmolar, but there's no statistically different signification. And also, if we look at the number 100, isoosmolar is better than intra-arterial low osmolarity. Why such a differences in criteria? And the reason is that many of these studies has based in heterogeneous studies. The radiological procedures are different volume of contrast, different definition of contrast-induced nephropathy, different group of patient, hydration, different amount of nephrotoxics, and so on. But if we look at this paper, it's a very extremely interesting. This is the Mayo Clinic study, in which is osmolar contrast media, and patients who underwent non-contrast computed tomography examination are included in the study, with more than 5,000 patients with even severe chronic kidney disease. And they found at the end of the study is that among patients at the highest risk of post-contrast acute kidney injury, Intravenous administration of isoosmolar iodixanol, for contrast, was not independent risk factor for acute kidney injury, dialysis, or mortality, with the same results as the patient with receiving non-contrast compute tomography. This is very important conclusion. And also, the conclusion of the European Society of Radiology are completely inconsistent with the European and American recommendation. These are data from the NICE, and you can see here that the incidence of contrast-induced nephropathy is lower with isoosmolar. This is the KDIGO, which is the renal group for guidelines, that wherever possible, isoosmolar agents should be used in people with chronic kidney disease at high risk for acute kidney injury. Also, the American Society of Nephrology, renal protection include isoosmolar contrast media. Also, the American Society, the Onconephrology curriculum, in which they also recommend isoosmolar in patients with GFR lower than 60 milliliters per minute. So, to finalize this, this discussion, cancer patients should be considered at high risk for acute kidney injury, including post-contrast acute kidney injury. So we have many procedures and treatment that we should personalize in order to protect our patient for contrast-associated acute kidney injury, including hydration, reduction in the volume of contrast medium, timing in relation to other potential nephrotoxic drugs, and particularly the choice of contrast medium type, including isoosmolar contrast in patients with high risk. And cancer patients, they are at high risk for acute kidney injury. Thank you very much for your attention.
Thank you, Dr. De Francisco, for your valuable lecture. For sure, it's quite clarifying to revisit this topic in deep with updated information, seeing how endangered the kidneys are all the time, like living in a high altitude. So it's quite important to take care of kidneys as long as they are being very helpful for our healthy economics as a whole. Some questions just to warm up our session. There is a general question that is always seen for other therapeutic areas. Does one size fits all? In this sense, does one contrast media fit for all patients? Or should we have at least one alternative in case a patient has comorbidities or additional needs?
That's a very good question, Ricardo. Trying to summarize, I think that intravenous administration in patients with the GFR over 60 milliliters per minute, I think that every contrast should be administered perfectly without any problem. The problem is when we have a patient, a high-risk patient with GFR lower than 60 milliliters per minute, and also you include cancer and diabetics, and this kind of patient, they are probably and also the ones who are receiving intra-arterial as well. So we have to organize the whole amount of different prescription related to intravenous or intra-arterial, GFR lower and higher than 60 milliliters per minute, age as well, of course, and then we should prescribe the ones who are less, who induce less damage to the kidney. So in high-risk patient, low GFR, and maybe intra-arterial, and also intravenous, we should take in consideration the possibility that the isosmolar is a more physiological approach in order to study our patient.
Thank you. Another question is there, as the patients with cancer need to perform repetitive contrast studies to see how the progression or the status of the disease, is there a healthy time limit for repetitive contrast studies while in cancer treatment?
Oh, okay. This is a state-of-the-art question, which is based particularly in how the oncologists they need to they know how the cancer is moving forward. They need all these data in order to investigate new drugs and so on. So, you know, I think that they should think about if such information could be extended longer than 3 months, every 3 months, and even try to extend to 6 or 1 year. But is this in a state of the art? They should think about what is the time they should investigate with the concepts related to the chemotherapy, no lower than 2 weeks at least. That's important as well.
Thank you. As a kind of a corollary of this question is renal function impairment limiting cancer treatment alternatives? I mean, if the patient has any kind of renal impairment, it will limit his or her alternatives for treat cancer more indeed?
Yeah, I mean, yes. If you have seen the renal functional reserve is a very important subject that still we don't know perfectly. And if we repeat and repeat and repeat, maybe that at the very end, including many other areas, not only contrast, but also chemotherapy, immunotherapy, other type of nephrotoxic drugs and so on. At the end, we have to take care about renal function, because otherwise, if there are some different treatment for cancer, which is, more positive for the patient, but due to the reduction of the renal function, we could, avoid or lose the possibility to introduce these new drugs or new things that to control cancer. Yes, of course.
Thank you. And finally, just not to leave aside a situation that we are living, does the renal function reserve being impacted by COVID-19? I mean, may we expect in the future even more patients with a kind of a hidden renal function at limit or a limited renal function after the COVID pandemic?
Yes, this is what is the long hauler or the post-acute COVID. This is extremely important question, Ricardo, because when you look at the kidney damage, what we have observed in COVID patient, hospitalized patient, we have different range with different papers, but at least between 30% and 45%, and even 80% in the ones who were in the ICU, and which is very high. And when these patients are discharged, more than 43%, exactly 43%, sorry, they have still unrecovered the kidney damage. So we probably would expect in the near future, unfortunately, more chronic kidney disease related to this post-acute COVID. We will see. It is very important to have particularly clinics directed to this post-acute COVID, So these patients, they should be centered in one single clinic, in which cardiologists, nephrologists, pneumatologists, radiologists, all of them, they have to take care of. Otherwise, if the patient is moving up to the pneumologist or to the cardiologist or to the, at the end we will lose the possibility to understand the disease because maybe the virus is still inside. That's one possibility. We will lose the possibility of epidemiological study to look for, and we lose the possibility to new advances in therapeutics of diagnosis in order to investigate and understand this post-acute COVID. Certainly, this is going to be work for the near future.
Thank you very much.
Thank you, Ricardo.